Kevin.
Thank you. Thanks. You're staying up or going down? Thank you very much for the opportunity to talk. I'm Kevin Flanigan from the Center for Gene Therapy at Nationwide Children's Hospital in Columbus, Ohio. And they used to say in vaudeville, never follow dogs or children on stage. And here I should never follow Anamika or Craig McDonald because they are such great speakers and tell the story so well. I'm going to talk about some advances in Duchenne muscular dystrophy, in cell, the title is Gene and Cell-Based Therapy, although I'm going to concentrate on gene therapy, and maybe some cell-based therapies will come up in the question and answers. Just a quick, I've got Pat's luck here with the advancement. How many advancements? There we go. So just a quick disclosure slide. And I'm going to talk a bit about gene replacement. Craig has covered so much the great, exciting news about Elevidys. We'll talk about a few other things. I want to mention briefly gene editing, surrogate gene therapies, and vectorized exon skippings to talk about where we're headed. And actually, if I have time, I'm going to close by a little sort of cautionary note to remind you that there are other potential therapies out there for parents, for families for whom gene therapy is not available that hold promise as well. Just another look at what we all know, but I know for some parents this is sometimes the first conference they've been to. If you've been here more than once or spend more than a few days here, you'll see many versions of a cartoon like this that show on top the organization of the dystrophin gene, which I don't have a pointer here actually, do I? So that shows the organization of the dystrophin gene, the 79 exons that go together to make the coding region for the protein, which is depicted as a yellow amino terminal binding portion of the gene, the C-terminal version that binds to dystroglycan, and that large interior rod domain that is sort of, we think of as a shock absorber, if you will, for the cell wall. This is what dystrophin looks like when it normally decorates the membrane of muscle. All muscle fibers sort of regularly shaped with dystrophin all the way around it. And in its absence, we get ongoing degeneration of muscle. Here in a picture cribbed from the website of Dr. Alan Pestronk, his great neuromuscular disease website, we can see evidence with a black arrow of fibers that are undergoing degeneration early on, and then regeneration, the small groups of fibers at the white arrow. And that process of degeneration and regeneration is what we need to interrupt to treat Duchenne muscular dystrophy. As it progresses, we get the kind of severe changes marked here with fibrosis, that thickening, that pinkness that's between each of the fibers. You can see that the muscle fibers are of all variable size and shape. We can see fibrosis and collagen deposition. We can see inflammatory cell fibers, for example. All of these chronic processes continue in Duchenne muscular dystrophy, and with the progression, there's the loss of muscle function. I don't need to tell parents here what Duchenne muscular dystrophy looks like, but I want to point out that problems with the dystrophin gene actually go with Duchenne and Becker muscular dystrophy. And Anamika mentioned earlier about the distinction between these. I'm going to just touch on it once again. But we have to remember that Becker muscular dystrophy encompasses a lot of things. We define it clinically, really, by boys who walk. Historically, it was defined generally by boys who walk beyond 15 years. They look different than boys who are off their feet by 12 years with Duchenne dystrophy. These kind of splitting is a little less useful these days because we treat boys earlier with steroids. We have lots of things that we can do to keep boys walking for a few years longer, but they're still useful in thinking sort of classic Duchenne versus something milder. But one important thing is that, in fact, problems with dystrophin gene can be associated with very mild versions of problems of Becker muscular dystrophy. So Becker is this, it could mean boys who stop walking at 20, it can mean men who stop walking at 60. All of those things are what we talk about as Becker. So when we think about somewhat simplistically treating Duchenne and turning a boy with Duchenne into Becker, we have to also ask what kind of Becker does that mean? How much function can we get out of it? So the important thing is this is a continuum, and we'll come back to some issues related to that as we talk about some new treatments. Mutations, we often skip and think about exon deletions as mutations. Exon deletions account for about 2/3 of the deletions in this huge gene that's spread all the way across 2 million plus bases, nucleotides within the dystrophin locus, the biggest gene we know. But large deletions of one or more account for about 65% of mutations. The remainder are a variety of mutations, and at the end I'm going to come back to the duplication group, which is a small subset of patients, but holds promise for a different route to therapy, and it's one that our laboratory concentrates on quite a bit. This is, Anamika mentioned before, we didn't coordinate too much, so I'm going to replicate one or two things she said about the reading frame rule. Oops, there we go, the reading frame rule. And this is the reading frame rule that says when we read the open frame, the way a protein is translated from the final blueprint is that those things we call in-frame mutations allow translation of a partially functional protein that leads to Becker muscular dystrophy, or it leads to no protein at all, Duchenne muscular dystrophy. And this is the basis of two groups of therapies right now, exon skipping therapies and micro-dystrophin therapies. In exon skipping therapies, another way of demonstrating what Anamika showed before is this sentence. I apologize, those of you who've been in my clinic, you know this sentence because we've done it before. But it's useful to remember because it's an easy way to think about it. The genetic code is read in groups of 3, much like this sentence is read in groups of 3. And it makes sense to us all the way through. We can take out a single exon and we shift that reading frame. If we take out just exon A, we get an out-of-frame deletion. We shift how we read it. It no longer makes any sense. If we take out, in addition, exon B, we can restore the reading frame. And it doesn't have quite the same function, but it has some function to it. It has some sense to it. So this is a restoration therapy and really makes use of the idea of restoring a reading frame, something we'll come back to for some therapies. The therapy that does restore reading frame you heard about earlier, exon skipping therapies. Many of you, your sons are probably on exon skipping therapies for 51 or 53 or 45 skipping. This example is what you saw before. Here, the example is skipping exon 52 to allow the reading frame to match up. And this is the basis of these approved therapies in which antisense oligonucleotides, small pieces of DNA, are used to bind to the pre-messenger RNA before things are spliced together to mask one of the exons, like that little red piece labeled AON, to mask one of the exons so it's excluded from the final messenger. So that's one way to do it, by antisense oligos. I bring this up, I'm going to come back at the end to another way to do it, another way we can now do exon skipping. You've heard about viral gene therapies, a little bit about terminology and what these viruses do. AAV, adeno-associated virus, is the workhorse of gene therapies today. Adeno-associated viruses are quite safe. They're found in the environment. They're not associated with any known diseases at any appreciable frequency. They have wide tissue tropism, which means they like to go to many different tissues. And essentially, at any level relevant to what we're really talking about, they don't get integrated into the chromosome. So they sit as a separate piece of DNA in each nucleus. They're taken up by the cell. They are stripped of the membrane of the proteins that encompass the virus, that cover the genomic payload. The genomic payload is brought into the nucleus, and there in the nucleus they sit as what's called an episome, a small fragment that is not integrated into the chromosome. And that gives an extra measure of safety. If you integrate things into a chromosome, you risk damaging an important gene and causing problems. There are problems with it. They can elicit immune responses, and they're limited in capacity. They're limited to about 5,000 bases of capacity. And the dystrophin gene, the final coding gene, is about 11,500 bases. So that's why we have to use micro-dystrophins. So the concept of micro-dystrophin actually goes back to a very early paper from named Kay Davies' lab, who defined a patient who was missing about 46% of the protein with a deletion of exons 17 through 48. And this picture shows, in a different version of the cartoon, the central rod domain, how much of that region was deleted. And this was a patient who was ambulant about at least age 61. And this observation, not long after the dystrophin gene was discovered, is actually the basis today of exon skipping therapies and micro-dystrophin. So soon after this work was done, people started thinking about how could you deliver or substitute micro-dystrophin. And in fact, the landmark work by Jeff Chamberlain and Scott Harper. Scott's a colleague of ours at the Center for Gene Therapy. He did his thesis work and published this, looking at the modularity. What could you take out of the protein? How much can you take out to still make it functional? And they published this work in this classic figure down here. And I'll point out one of these, the third from the bottom, R24 to R23, is in fact the exact peptide that's delivered. It's the same protein that's expressed by Sarepta's product today. So this was the delivery of that was further refined by Dr. Rodino Claypack and Dr. Mindell in the laboratory. But in fact, there are multiple versions of microdystrophin, and I think most people are aware of this, but some may not be. They all differ in little different ways. So Sarepta is on the top, showing their promoter, MHCK7. At the far end, the virus they use, RH74. And the regions of the actin binding domain, a hinge, the repeat elements. I didn't define those repeat elements, but those are called spectrin repeat elements that make up the separate central rod domain. So these all differ a little bit. Pfizer has one that's slightly different. Solid Biosciences has had one in trials that's slightly different. Genethon, a different promoter, a different capsid. And although the cartoon's a little different, the latest entry in the race is REGENXBIO, who has yet another different one. Differs primarily in the inclusion of the entire C-terminal region of the gene that's slightly distinct. So when we think about microdystrophin, with all of the excitement of the approved drug, the accelerated approval so far, there are other candidates out there that are in studies, as I'll show you. I'll show you a little bit. Dr. McDonald showed that was a great review of all of the data supporting the accelerated approval. Here's just a paper, the first paper showing expression of dystrophin, and you can see where the red boxes are at the bottom. Those are called Western blots, and post-treatment, each of those lanes represents a muscle sample, and you can see expression of dystrophin at relatively high levels from each of those patients in this first publication related to microdystrophin, a landmark publication. You'll note too that it's different in size. Rather than on the left of each of those blots, those dark, looks like streaks almost, that's the normal size dystrophin at 427 kilodaltons in size. Those are arbitrary units, if you will. It's about 138 kilodaltons in size. So you can tell that it's a microdystrophin. I won't reiterate all of the things that Dr. McDonald just showed you. I'll just point out this is data on expression. And you can see here in the bottom, percent dystrophin positive fibers ranging from about 80% in one study to 103 to about 48%. This was the data that went in with Sarepta's request for approval and so on. And so, and you saw the data that shows some correlation between some of those patients showing quite a bit of expression, although not a perfect correlation between the amount of expression of dystrophin and function. I won't reiterate this. Dr. McDonald, Greg showed this great data. This is the biggest news, obviously, in gene therapy. Our disappointment, our limitation of this treatment, boys of 4 to 5, is a limitation, and exclusion of boys with deletions of 8 through 9, that's related to issues of safety that I'll touch on in a moment that seem to have arisen, where some immune responses are particularly generated to that version of the neodystrophin that's expressed, the new dystrophin epitopes that are expressed in patients. I do want to take one pause, though, to step away from what's new, to just have a few things, while I have the opportunity to share with parents, that it's worth being aware of a few things post-approval. I think every parent is aware about the 4 to 5 limitation, the age range limitation. But you know, we are already at our clinic, and I'm sure in many of your clinics, you may have called your local clinic already and said, when can we get this? We're ready to go. But I want to remind everybody that these are actually very complex processes to get the vectors ordered and paid for, to deliver, to safely deliver, and set up the appropriate monitoring that needs to occur at every institution. So I think we're a little bit set up as a community for disappointments when families say, how come it was approved last week? Well, how come I can't get it next month? As one example, virus isn't even going to be delivered for almost 6 more weeks to institutions. So we still have, we don't know what all insurance companies are going to pay for this. So I urge you, for those of you who are eligible for this therapy, as you approach your clinics, your CDCC, care centers that you keep in mind there's a lot of complexity. There is an intense monitoring that will be associated with this. In some ways, this is like a transplant of a single protein. We need to have safety first. So I just want to assure everyone that every clinic that I'm aware of in the country is working as quickly as they can to get this in place. But I want to urge everyone to understand that there is complexities in ensuring access to it for everyone at a reasonable speed. So please keep that in mind as you have the chance. So I know individual centers are working on resourcing, staffing issues, and so on. Some are a little ahead of each other, but it's going to come out to a lot of places fairly soon. I will point out that there are ongoing trials. Pfizer's trial is now fully enrolled, and we should have more data from them in the time frame of the first quarter of next year. Solid Therapeutics, some people in this audience might have taken part in their trial as it began. They are now actually intending another trial using a novel version of a capsid, a different kind of a viral envelope to deliver this. And REGENXBIO has now begun dosing patients in their trial as well. So the landscape's changed a little bit. The approval allows us to treat many patients. The requirements for these, I won't go over each of the requirements for them. We can, in discussion, we can talk about them, or you can find them online that allow other boys access potentially to gene therapy approaches in a trial setting. There are challenges that remain to gene therapy, tropism, getting it where we want it. You've heard about 2 deaths with gene therapy so far. That occurred, and one in the Pfizer trial and one in an N of 1 trial that was not related to the studies we've shown so far. So we want to do anything we can to maximize delivery to skeletal muscle and minimize the total dose we have to do. And there's a lot of work right now going on in the field to do improved vectors that detarget the liver, which acts like a sponge and likes to take up AAV. So there's a lot of work on novel capsid development. Another question is about durability of expression. We need to find that. When we see data from 5 years out of gene therapy, that's so promising. That's what we want to see, persistence. We don't know everything about persistence. One thing I'm going to stop a minute to talk about is immunity to the transgene. So when we deliver a transgene, we deliver a protein product that the body's never seen before, we have the possibility to develop immune responses to it. In fact, we have 2 sets of immune responses we worry about when we deliver gene therapy. Our body has what's called innate immunity, which is not learned immunity, but it's our natural response to any sort of pathogen that enters the bloodstream. And this centers on really rapid responses, including ones that go through the complement pathway. And in fact, in the early sort of toxicity we look for with gene delivery, where platelets can be degraded, where we can see acute changes related to many different organs, that's associated with complement changes, and it's our worry initially in the first time period of gene delivery. And then once the gene gets expressed, the protein itself has the potential to develop immune responses. That's the second kind of issue that's arisen so far in the multiple trials. So I mentioned this acute reaction to the risk over the first week or so, and then longer term related to immune responses. The biggest of these so far is what's really called an autoimmune myositis, in which expression of the dystrophin gene in muscle has led to 5 cases described across 3 different programs so far that shows that has led to profound weakness of the muscles, including leading in a couple of patients to hospitalization and intubation, requiring further immune-mediated mediation. And then examples of myocarditis as well, associated with gene delivery. This means for patients who are going through gene therapy, there's going to be really intense monitoring of immune responses and other markers of inflammation and function. So there will be on the order of 3 months of weekly laboratory values to monitor this sort of stuff. Oop, I've gone once too far, I think. I do want to point out, I just want to put a shout out, the community is coming together to try to define these in ways. In fact, Dr. Karsten Boneman from the NIH and Francesco Montoni from University College London have organized really a working group to promote the sharing of data about these things, and remarkably have gotten a buy-in from multiple companies. We need to applaud Sarepta and Solid and Pfizer and Genethon for getting together and sharing unpublished data to say, for the purpose of the safety community, what's similar in responses in unanticipated events seen across these different programs. So it's an effort that's going to continue. I do want to just add, though, as we think about toxicity, I never miss a chance with a parental audience to highlight one of our challenges that we have. We always look for liver inflammation in response to gene therapy with any of these viruses in any disease, and we have an extra challenge in Duchenne dystrophy because if you don't know it, what we commonly call liver function tests, the AST and ALT, are actually, they're enzymes that are released by muscle. And in boys with Duchenne, they're uniformly elevated as well. So we don't monitor them as absolute values, but we monitor them as multiples of the screening value. I bring this up because every year in our clinic, we meet some child with a new diagnosis who has had a liver biopsy as part of their diagnosis before someone checked a CK. So keep that in mind when you go through any of these things. The liver function tests reflect not just liver function, but what's going on in muscle. So I'm going to jump to some of these new approaches. I talked about gene replacement. I want to touch briefly on CRISPR. CRISPR technologies would be its own talk. Maybe some future time we'll do a whole session on them. But this stands for, well, CRISPR is an acronym for clustered regularly interspersed short palindromic repeats. What this really consists of is Cas9 nucleases that are targeted to certain regions to give specific approaches to editing the gene at those regions. What it does in its basic form is to cleave to damaged DNA at really specific areas, and then the cells respond by repairing that DNA. So what we mean by CRISPR therapies, what we mean by that depends on what we're trying to do, what pathway we're trying to use to repair, what we're trying to damage. There is no one CRISPR therapy for DMD. That's important to remember in parents. And so we design these to therapeutically cut the target so that the repair repairs the gene. This makes use of a system that uses a guide RNA that recognizes exactly the target that we're after, and the enzymes that act as these slivers here to cut the double-stranded DNA. And then this is a complicated figure, but two different pathways exist in cells to repair it. One requires machinery to rejoin pieces of DNA, and that can be done at a relatively low efficiency in a way that you can use, for example, CRISPR to cleave an exon targeting site, an exon definition site, and the restoration of the DNA ablates that site at some frequency, allowing skipping of that exon from then on. The other way is to put in a piece of DNA called homology-directed recombination. That's a more difficult process in muscle because that pathway is not active in muscle. But I bring this up to point out to say there is no one CRISPR. Parents sometimes come into our clinic and say, when can I get CRISPR? When can I get it? I want to do CRISPR. I can't get gene therapy. I can't get gene replacement therapy. We want to do CRISPR. Well, there's a lot of different approaches that different groups are using for these to use CRISPR-based technologies. There are challenges to it. One challenge is delivering everything in one virus. Some of the things are going to be two viral systems for it. Targeting muscle, which can be up to 70% of muscle mass, to do that efficiently and specifically is difficult. And how do we avoid off-target effects? How do we make sure we don't damage DNA at the wrong spot? It's moving forward. I don't want to give anybody the idea that in general there's one thing just ready to go. I want to talk about a different approach, though, and show some data that we published last year regarding what's called surrogate gene therapy. So an alternative approach to replacing the missing gene or a small version of the missing gene is to put in a gene that can substitute for it. So in this example of surrogate gene therapy, it uses something called GALGT2. GALGT2 is an enzyme that's expressed in muscle. It's usually expressed only near the myotendinous junction or where the nerve meets the muscle, the neuromuscular junction. And in fact, what we think of as the dystrophin-associated complex is different at those locations. The dystrophin-associated complex is shown extrasynaptically, away from the synapse, On the left, it's got dystrophin, binds to dystroglycan and a whole bunch of other proteins, anchors to the matrix, stabilizes the protein. That's the dystrophin-associated complex. However, at the synapse, utrophin substitutes for that. And at that spot, that's also where GALGT2 is expressed. And it turns out that if you take a mouse lacking dystrophin and you overexpress GALGT2, you can essentially turn the entire the dystrophin-associated complex is restored, substituting utrophin for it across the entire membrane. And in fact, this is not only through utrophin, a whole bunch of different proteins that are known to stabilize the membrane interaction with the extracellular matrix are also restored. They're listed down here: alpha-7, integrin, plectin, agrin, and other ones as well. So this, actually, we delivered this to 2 patients. Only 2 patients because a foundation paid for the development of this at a time when we anticipated to do it only in muscle, intramuscularly, but the field had moved on and we had safety data to say it was safe to put it in animals. And we did what's called isolated limb infusion, where it was delivered into the vascular limb of either leg, actually eventually both legs in each boy who underwent it. It was done by inflating a balloon to keep the circulation from going, inflating a balloon in the femoral artery and in the femoral vein, letting it dwell in there for about 10 minutes, and then letting the balloons go down. We don't use this anymore. This is not an approach we would use routinely. This study started about 4.5, 5 years ago, at a time when that was still considered to be a viable approach to maximize delivery to muscles and to maximize use of a very limited amount of tissue, amount of virus. But you can see we have 2 boys who were enrolled: an older boy at 8.9 years old and a younger boy at 6.9 years old. And this is a little bit difficult to read from the back, but the difference between the 2 boys are a couple-fold. One is that the older boys, as sort of withdrawn from care, they made some changes on their own to steroid regimens. They'd hoped the drug would mean they didn't need steroids anymore. And this is one of the problems for us in clinical trials, that we, and in therapies, we make implicit agreements with families about following recommendations and so on, and if we can't, once we've given this therapy, we can't. There's no way we can enforce that. I will say we did get a 2-year follow-up data on the boy at a lower steroid dose than we want, and that's the boy who did decline in the ability to perform 6-minute walk, and he lost the ability to stand up off the floor. The other boy treated at 7 years old, he's now 10, and we have 2-year data shown here that shows stabilization, time to rise, stabilization of his North Star Ambulatory Assessment score, stabilization of his 6-minute walk time. And he's done actually very well. Let's see, these are supposed to autoplay. This is him at age 10 on the left. This is him getting up off the floor at age 10. And this is him running in the center at age 10. None of this is perfect, I'll grant you. None of these look as nearly as nice as we saw the examples of several of the boys from the other study. We didn't see all of the boys from the other study, but we saw the examples of several of them. And we can see that, 3 years out with this surrogate gene therapy, he's continued to do well, and his parents remain equally pleased on how he's done. So it opens the opportunity that surrogate gene therapies remain a viable approach. This remains licensed as Sarepta gene therapies, and we're hopeful that Sarepta will continue to carry it forward as an alternative, particularly as because this is an approach in which transgene immunity would not be expected. Everyone carries that gene. Now, another approach we're very excited about uses what's called U7 small nuclear RNA. And this is the vectorized exon skipping. So this is a way to restore, the example I'll show you is to restore full-length dystrophin expression. In this example, we use a gene, we deliver a gene that's a non-coding gene. So this is a gene that's never turned into a protein. This gene makes a fragment of RNA. It's a gene that is usually used in the processing of a gene called a histone gene. And there's a fragment at the end of the U7 RNA that localizes it to the histone gene to help in processing. So we hijack that fragment. We redirect it. We put in a sequence in there that is an antisense sequence to our gene of interest. In fact, we targeted exon 2 to start. Why did we start at exon 2? Well, exon 2 duplications is where we started because that's the most common duplication. And we knew that if we skipped exon 2, we had a wide range of safety. The reason for that is this. Exon 2 duplications are common. They're all over the place. They're about 10% of all duplications of the gene. They're associated with Duchenne muscular dystrophy. And we know that deletions of exon 2 are uncommonly reported. The reason they're uncommonly reported is because there's something called an internal ribosome entry site downstream of exon 2. An internal ribosome entry site is an area of a gene where you can have antibodies that, where you can reassemble the machinery for translating a protein. And we know that internal ribosome entry site is not active in the presence of a duplication of exon 2 and fully active in the presence of a deletion of exon 2. And we found patients with that. We know now about 10 patients with deletions of exon 2, and they have no symptoms whatsoever. Their CKs are high, but they walk just fine. And we know other people who make use of these mutations who are 80 years old who carry it and are walking fine. The one patient we know who expresses this version of the protein derived from the internal ribosome entry site. The one patient we know stopped walking at age 70. So that gives us this big window. We have a therapeutic window. If we want to permanently skip exon 2, we're either going to make normal protein or we're going to make a version that lets you walk to 80. So we put it into a viral vector that contained 4 copies of this. Let's see, 4 copies of this, 2 of them targeting the splice donor and 2 targeting the splice acceptor site. And we showed that it was safe and it didn't skip anything except what we wanted it to skip. And we started a trial with 3 participants. This too was funded by a foundation, so we only had enough to treat 3 boys. And I want to call your attention that we treated an 8.9-year-old boy weighing about 23 kilograms or about 70 pounds, a 13-and-a-half-year-old boy of 58 kilograms, about 130 pounds, and we only had enough left to treat an infant at 7 months of age. So the results are really quite striking. So this is the data, subject 1, subject 2, subject 3 is the infant. This is the AST and ALT data. We see spikes that go with treatment with any AAV virus, that's common. But it's the CK data in the lower right that I want to show you. All of them had really quite suppressed CK. Any parent here knows CK goes up and down with activity. If a boy goes to a birthday party, his CK could be twice as high than the day before if he runs around a yard. But in an infant, it's preambulant. So this is not anything related to activity. His CK went from above 15,000 on the day of treatment to 1,000 and stays 1,000 down at 12 months. So this infant is now, that's a measure at 19 months of age. So, very busy slide, bear with me 1 minute. I don't have a pointer to help me. What I want to show you is that on the left side is how we measure. How did we do at exon skipping? The gray bar shows us how many copies of the messenger RNA contain just 1 copy of exon 2. The black bar shows us how many copies contain no copies of exon 2, what percentage contain no copies. And you can see an obvious difference. We can see that we got exon skipping in the first patient, the 9-year-old, 8.9-year-old. We didn't get as much in the 13.7-year-old, and we got wild amounts of exon skipping in the infant. Then we look at protein. When we look at the protein by Western blot, how much protein do we get? We got about 7% 1 year in the 9-year-old patient. We got about 1.5% in the 13-year-old patient. And we got levels of close to 90% of dystrophin, of wild-type dystrophin, looking normal size and shape. This is a way to show that by immunofluorescence. A very busy slide, and forgive me if you look at the third one down, that's how much dystrophin that patient has. You can see we have dystrophin in about 44% of fibers at 1 year in the 9-year-old patient, 8.9-year-old patient. In the older patient, 13.7 years, we have got about 7%, 6.75% of fibers showing dystrophin positivity. And what you see at the bottom is a heat map to say how positive is positive. Is it 50% positive, 60% positive? How much of the circumference is positive? The infant, we get this. In the infant, we have what looks like absolutely normal dystrophin. And again, this is wild type, or what appears to be full-length dystrophin. Some of it could be that slightly shorter version that's associated with walking at 70. And we get that up to the age of about at 12 months of age. He's completely normal development. So we're very excited about vectorized skipping. It is more functional than, it seems much more efficient than the kind of exon skipping where you take a drug for exon skipping. And there's at least 2 companies that presented the American Society of Gene and Cell Therapy that showed delivery of this for more common exons. Sorry, I'm running out of time, aren't I? I really apologize. Let me show one last thing, then. I'm going to just show one last thing. While we're on exon skipping, forgive me. I got many more slides, but I just want to stop on one last one. Last two slides. This is a horribly busy slide. But I want to point out now in the age of availability of Levi-dis that there might be patients for whom we can get a better version of the protein with existing drugs. So what we did was we took patients who had duplications of either exon 53 or 45. We invited them to participate in a trial where we gave them either golodirsen or casimersen, which are commercially available. And we treated them for a year. And with the hypothesis that it would make more dystrophin if we're taking out one copy and making a full-length dystrophin protein, we're going to do better. That's a more stable protein. Full-length dystrophin has to be more stable than the micro-dystrophins that are made by exon skipping therapies. So this is terribly busy and hard without a pointer to show. I will point you out, the best thing would be to look at the second row and say we can make significant amounts of dystrophin, of wild-type dystrophin, even in boys who are old. So I'm going to show you the subject number 3, who's 18 years old when he started treatment. And this is this boy. So I didn't quite believe his mom said, when we started to make levels of about 8% of normal dystrophin with a treatment for a year with this, she actually said, hey, you know, he's getting better. And I've never seen an 18-year-old boy show improvements in function. She said he was now able to remove a shirt, what he couldn't do, reach down in his wheelchair and pick things up off the floor. And then when she told me now, a year and a half out on the drug, that he could sit up in bed, I couldn't quite believe it. He's starting at an angle, obviously, but this is him sitting himself up, which he had lost the ability to do. So I only bring this up to point out that there are potential options. And if your child has a duplication of an exon for which a common drug is available, one might consider whether one's better off trying to make full-length dystrophin in those conditions than others. And I'm happy to talk to anybody in that kind of position about it. So that I'm going to close. That's it. I'm sorry. I'm overdone. One last thing I do want to thank. I have to thank PPMD. I'm sorry. PPMD has generously supported our annual myology training course. We train young physician scientists from around the world. We've done over 600 young trainees who've been trained. And really, it's because of the support of PPMD that we've done that. And I apologize. All I can claim is there was no clock down here to keep me going, so I knew what time it was.
So now you have to sit.
Okay.
Thank you.
How far did I go?